So, like Dr. Mitei said, my name is Dr. Anna George. I am a urogynecologist, which means my primary specialty was obstetrics and gynecology, and then I specialize in female pelvic medicine. I have a special interest in fistula surgeries and fistula work just because of the patient population, which is something that's very dear to my heart. I work in America, but I'm originally from Nigeria, so I'm a home girl. So Dr. Mitei wanted me to talk about overactive bladder today, which is something that is very common and is another cause of urinary incontinence. So the International Continence Society defines overactive bladder as a syndrome that consists of urinary urgency with or without incontinence. It's usually associated with frequency and nocturia in the absence of a causative infection or a pathologic condition, which means that you can't really find something that you can say is the cause of that particular symptom. So there's no urinary tract infection, there's no pathologic condition, it's not neurogenic or physical in origin. So it's usually idiopathic. I'm going to give you the definitions of the terminologies that I just used. So urgency is defined as the sudden compelling desire to urinate. So the patient really feels the urge to urinate and cannot defer that sensation. Then there's urgency urinary incontinence, and that's urinary leakage that's associated with that sense of urgency, and it's one of the most common types of overactive bladder. Frequency is how often a patient urinates, and that is defined as urinating 8 or more times in a 24-hour period. So the average number of times a person should urinate in a 24-hour period should not be more than 8 times. And then there's nocturia, which is defined as the need to wake up 1 or more times at night to urinate. So when a patient presents with urgency urinary incontinence, they complain of involuntary leakage with or without that sensation of urge. And it's because there's a loss of a cortical inhibition of the bladder, which means, as we all know, when we're growing up, we just urinate, right? Babies wear diapers and they just urinate. But as we're growing up, we learn how to control when we urinate. Okay, and that's because our brains, which is referred to as the cortex, the higher centers, learn to control the urge to urinate. So even if we feel the urge, we should be able to suppress that urge until it is appropriate to urinate. In an overactive bladder, we lose that inhibition of being able to control when we urinate. And it's a sensory afferent disorder. It can be caused by neurologic disease, bladder or urethral pathology. Sometimes medications can cause it, but most commonly it's idiopathic, which means there's no real cause. So I'm just going to go over briefly the pathophysiology of normal bladder function. Okay, the way the bladder functions is very complex, and it's a coordination of several things. One is musculoskeletal, neurologic, and psychological functions allow us to control how our bladder feels and the emptying. There's a synergic relaxation of the detrusor muscles, so which means that synergy just means that things are working together in cohesion. So the bladder muscles relax, the detrusor muscle of the bladder relaxes, while the neck of the bladder, the muscles around the neck of the bladder contract, and the pelvic floor muscles also are kind of contracted as the bladder fills. Okay, as it fills, the sympathetic nerve fibers from T11 to L2, they cause that bladder neck and the proximal urethra to contract, and the detrusor muscles, which are controlled by a different part of the spinal cord, relax. So as the bladder fills, there are sensory stretch receptors in the wall, and it's that stretching of the bladder wall that triggers the central nervous system to say, okay, maybe it's time for me to urinate. While the bladder is filling, the pressure within the bladder itself stays very, very low. So if you think about it, if you start filling a balloon with water, the pressure inside should fill until it bursts. But the way the bladder muscles are arranged, they're not arranged in any symmetrical way. The walls of the bladder, the muscles run in all sorts of different directions. So that allows for the bladder to fill with a very, very low pressure. So your bladder can just fill and the pressure just stays very low until it gets to a certain point where it's stretched enough that the receptors, the stretch receptors in the bladder wall trigger a sensation, brain saying that it's time for you to urinate. So the property that the bladder has to expand with low pressure is called a viscoelastic property, and that's what the bladder has. Okay, and while it's doing that, it antagonizes the parasympathetic nervous system so that it stays quiet. So what the parasympathetics do is they cause contraction of the bladder muscles, those very relaxed muscles. So when they contract, that's what makes us urinate. So while when the bladder contracts, the muscles of the bladder, of the floor of the pelvis and the neck of the bladder should relax. Because if they're contracted, the bladder is relaxed. When we want to urinate, these muscles relax and then the bladder contracts. Okay, so we don't really need to help the bladder empty itself. If you sit down and you tell your brain that I'm ready to urinate, automatically the bladder neck relaxes, the floor of the pelvic floor muscles relax, and the bladder contracts. So we shouldn't really be pushing to urinating. We should just sit down, relax, and allow our bodies do what's normal for them. So I'm just going to move on. So how do you diagnose and manage overactive bladder? So the important thing to realize and to communicate to patients is that this is not a disease. Overactive bladder is not a disease like malaria or hypertension or type. It's not a disease, but it's a symptom complex, and it's generally not a life-threatening condition. We usually say that when we want to treat or diagnose this, or we tell patients that it's not something that we're looking to cure. It's something that we want to control because it's a combination of symptoms. That's why it's called a syndrome. So the basic diagnosis is just a history and physical. You do a urinalysis just to look for things like blood or evidence of stones, which could mean that it's something else that's causing those symptoms. A urine culture, because if a patient has a urinary tract infection, it can look like an overactive bladder because they have the urgency, the frequency. The difference is that they may have dysuria, but if they have a long, chronic, low-grade infection, they may not even have symptoms apart from just the urgency and frequency and leaking associated with it. And then if you're not too certain about what's going on, you can do something called a bladder diary. So a bladder diary is basically just having the patient record over a 24-hour period certain basic factors. So how much fluid are they drinking? What time are they drinking that fluid? How often are they urinating? When they urinate, do they leak before they get to the bathroom? Do they wake up at night? So you record the amount of fluid that they drink over a 24-hour period, including at nighttime, the number of times they urinate over that same 24-hour period, including how many times they get up to urinate at night. And based on that, you can figure out if they are urinating normally or not. So if they're urinating less than 8 times, then they don't have frequency. But it doesn't mean they do not have an overactive bladder, because they could urinate like a normal person, but every time they need to go, they may not be able to defer the urge and may even leak urine. So that's still an overactive bladder. If they're waking up at night to urinate, that's also a sign. So there's a very simple way to test for it in the clinic. It's called simple cystometry, and we did a few of them yesterday. And all you do is just get a Foley catheter and get a 60 cc, what do you call them, urinary syringe? The syringe, yeah. You put the Foley catheter in the patient's bladder, drain the bladder so the bladder is empty. Attach the syringe to the catheter and just slowly fill the bladder up. But you want to hold, I'm sorry, this is going to be not a very easy picture to see but you want I don't know if you can kind of see it with an eye of faith. You want to hold the syringe at the same level as the patient's pubic bone and just slowly fill with water. If the patient has bladder contractions, which is an overactive bladder, which means that it doesn't matter how much fluid is in the bladder just wants to push it out. You're going to see that the meniscus in the syringe starts to rise and may even spill over. Okay, and that's a classic sign of detrusor overactivity. So if you see that, you can say the patient has detrusor overactivity. If it's just based on the symptoms, like we've just talked about, we call it an overactive bladder. So that's just kind of like, it's the same thing, but one is you actually have a diagnosis because you saw it on testing, and one is just based on clinical history, and they're exactly the same thing. It doesn't take away from the patient's symptoms. So how do we treat an overactive bladder? I'm going to tell you about first-line treatments, second-line treatments, and the third-line treatment. The first-line treatment is basically lifestyle changes. So bladder training, you try and teach the patients to kind of retrain the bladder like we did when we were children and growing up, and we had to learn our potty training. So with patients who are urinating very frequently, you try and teach them to slowly increase the amount of time between each urination. So the patient's going to tell you, oh, I urinate 15 times a day. So you're going to the bathroom every 30 minutes to 1 hour. So for the first week, you want them to try and suppress the urge to urinate for maybe 15 minutes until they get comfortable with it. And then the next week, you have them increase it by, a certain amount of time until you get them to where they can delay the urge by up to maybe 2 hours, okay? And it's just kind of like trying to get the cortex, teaching them pelvic floor exercises, which we will talk about at the end of this discussion. Then bladder control strategies are things that some people will say, if I hear running water, and we all did that to children when we want them to urinate, we tell them, okay, go pee, and they're not ready to urinate, and you turn on the tap. And that triggers the sensation to urinate. It happens to us as adults too, and people with an overactive bladder will tell you, I'm trying to wash dishes, and as soon as I hear the water running, I lose my urine. So you try and see if you can break those connections and teach them how to control that sensation. Then the pelvic floor muscle training, which most people call Kegel exercises, which we will talk about later. And another important thing is fluid management. Because if your bladder is overactive, you want to reduce how much fluid you're drinking, because if you drink a lot of fluids, you're going to make a lot of urine, and it's going to be a little bit more difficult. You'll find out that most patients who have an overactive bladder will actually, just without even thinking about it, start reducing how much water they drink or how much fluids they drink, just so that they don't have to go to the bathroom that often. And you also have to be cognizant of the fact that there are certain things that we eat and drink that will irritate the bladder and make us go to the bathroom more regularly. For us here, tea. We drink a lot of tea, okay? And tea has caffeine in it, and it's a bladder irritant. So patients with an overactive bladder will say, I drink my cup of tea in the morning and I have to go to the bathroom and sometimes I can't make it. Well, those are people that might have to either stop drinking tea or reduce how much tea they drink. And that might be all that they need. So second-line treatments for an overactive bladder, we're talking about medications. And the most common medications that we have are the anti-muscarinics. Sometimes we call them anticholinergic medications. And the oldest, cheapest medication that I know is called oxybutynin. But Dr. Mitei says that here we have solifenacin, which is actually a newer generation anticholinergic medication. And the way it works is that the bladder has certain receptors called M receptors, and they're M2 and M3 receptors. It's not really clear how they work, but we know that the antimuscarinics attach themselves to those receptors and relax the detrusor muscle, so it makes it less sensitive and less likely to contract, and so patients can get to the bathroom. The problem with these medications is that those M receptors exist from our brain right through our GI system, the bladder, they're in most of the smooth muscles. So these medications are not specific for the bladder. They cause a lot of side effects because they affect other systems. So they can cause confusion, especially in older patients, because they cross into the brain and affects the receptors there. The most common thing patients complain about is constipation because they affect the M receptors in the GI tract, and so they slow the bowel down. They cause dry mouth, dry eyes. Okay, so they slow the bladder down, but they also pretty much slow everything down. And in my experience, there are a lot of patients who will kind of do okay with their bladder symptoms being controlled, but they cannot handle the side effects. So they're like, I'm not going to bother with the medication. I'll just be uncomfortable because they can't have a bowel, they're constipated, or they have dry mouth. And in older patients, especially after the age of 70, it's kind of tricky to give it to them because it can cause confusion, and then that increases the risk of them falling, especially at night, and having accidents, and we don't want that. So they work, but they are not perfect. Another important thing to realize is that once a patient starts his medications, they do not work immediately. So the one thing the patient will notice is if they're going to have side effects, they will definitely have side effects within a few days of taking the medication. But the positive effects of the medication may take 3, 4, sometimes a maximum of 6 weeks for them to see a full effect that the medication is actually working. So it's something to tell the patients that, you need to take it for this amount of time. And if after 4 to 6 weeks you don't see an improvement, then maybe we should change the medication or adjust the dose. Okay, so the medications come in either immediate release or extended release. So it's the same medication, but it can be an immediate release. So you take it and the medication gets into the patient's system almost immediately. And so the dosing is usually maybe twice daily. They also have the extended release where the patient takes it and it's released into their system slowly over a 24-hour period. The preferred dosing is the extended release, because that has less side effects just because it's released so slowly and it doesn't peak in the blood stream, so the side effects are slightly lower. Some of the medications also come in a patch form. If you try one medication for the patient and it doesn't work, you can try a different medication. The efficacy, I think, is exactly the same, but the different medications may have different side effect profiles for different patients, and so they may be able to tolerate one better than the other. So I think in the last 2 years, there's a new medication which is called mirabegron, and it's brand new. It's not an anti-muscarinic. It's the first medication in its class that has been developed for overactive bladder. And the way it works is it's a beta-3 receptor agonist. It's the first in its class. It's newly FDA approved for overactive bladder. And personally, I think maybe I've prescribed it once or twice because it's barely available, but it's good to know that it exists because I'm sure it's going to be pretty common very soon. It has less side effect profile than the anti-muscarinics because it works in a completely different way. And how it works is that it causes a dose-dependent relaxation of the detrusor muscles during the storage phase. It also inhibits the neurogenic detrusor overactivity. It increases the bladder capacity, but doesn't change the micturition pressure, which means that when a patient is urinating, the amount of pressure that the bladder generates for normal urination does not change. So it comes in 2 strengths, 25 milligrams and 50 milligrams. The one potential side effect to this new drug is hypertension because it's a B3 receptor agonist, so you have to watch a patient's blood pressure. It's not contraindicated in patients who have high blood pressure, but you have to monitor their blood pressure and make sure that it stays normal. So after medication and behavioral therapy, then there are third-line treatments for overactive bladder, which are much more invasive and probably won't relate to us here, but I'm going to talk about them. There's something called neuromodulation. And what neuromodulation does is that it uses the fact that our nervous system is what they call plastic. Plastic means that you can move something, in different directions. And because of the plasticity of the nervous system, we can change how things work. So with neuromodulation, we're trying to change the interaction between the nerves that control the bladder and the cortical center, the brain. There are 2 different ways to do it. You can do what we call sacral neuromodulation. I'll explain that. And the other one is percutaneous tubal nerve stimulation. So with the sacral neuromodulation, this is kind of a little like pushing the envelope. What we do with that, it's almost like using a pacemaker. So we implant a wire into the patient's back and have it lie next to the S2, S3 segment that controls the pelvic floor. And then there's a little battery that looks exactly like the battery for the pacemakers that they use for the heart, and we send electrical stimulations to that nerve. And because that nerve is being stimulated constantly, it interrupts the firing that comes from the bladder to the brain and is able to help patients control their symptoms. Now, it doesn't cure overactive bladder, but what the goal is that if it can reduce a patient's symptoms by at least 50%, then we say it's successful. And so we try it out for a few days, and if it works, we go ahead and do the full implant for the patient. Then the next, the other way to do it is what we call the percutaneous tibial nerve stimulation. Instead of going directly to the sacral nerve, we can use the tibial nerve because it has the same origin from the spinal cord as the S3 complex that controls the bladder. So it's a very indirect way of doing the neuromodulation, and because it's indirect, it takes a long time for the patient to see any improvement. If a patient is going to have this done, what they do is that we use a tiny little needle that looks like a needle that's used for acupuncture. It's not an acupuncture needle, it's not an acupuncture procedure, but the needle looks exactly the same. It's very, very tiny, very fine. We put into the patient's nerve and then attach the electrical stimulation to that needle, and so it keeps sending that stimulation to the needle. It's a treatment that we do for about 30 minutes, but it has to be done for 30 minutes once a week for 12 weeks. Patients usually begin to see that their symptoms may start improving somewhere at around the 4th to 6th treatment. Okay, we say that it works maybe 70 to 80% of the time. The one thing about most of the conditions in urogynecology or the pelvic floor that we treat is that we have to make peace with imperfection. We don't have cures for most of the things we do, but we can control patient symptoms. And so we're not going for cure, we're going for control and just improving the patient's quality of life. And so the one downside to this treatment is that after 3 months, if the patient is doing well, they have to keep doing that treatment at least once a month to maintain the improvement. So, if they fall off and miss 2, 3, 4 months, their symptoms are going to go back to baseline. And if they want to do it again, they have to start all over again. So it can be a little time intensive for the average patient. Okay. And then finally, we now have realized that Botox, which is botulinum toxin that we get from that's what causes tetanus, right? Yes. Botulinum toxin. And it's like the strongest poison, more or less, that causes neurogenic paralysis known to man. But now we have harnessed that, and we're able to use the Botox to treat overactive bladder. Because basically what's happening with an overactive bladder is the detrusor muscles keep contracting, and that's why the patient is leaking. So we can use the Botox toxin right now and just inject it into the walls of the bladder, and it relaxes the walls of the bladder, and that controls the patient's symptoms. Once again, we're not saying that we can cure it, but we can really control the patient's symptoms. And with all the treatments I've talked about, no one is better than the other. They're just different options for treating one condition. And, if somebody fails one, you can try another one. So it doesn't mean that one is better than the other. The thing is that the Botox causes the flaccid paralysis of the muscles. It doesn't last forever. It probably lasts somewhere between 3 and 9 months. So if a patient has Botox therapy, it has to be repeated, once or twice a year to maintain the improvement. Another caveat to that is that sometimes the muscles can be so paralyzed that now the patient cannot urinate and they go into retention. So there's a school of thought that if you're going to do Botox on a patient, you have to teach the patient how to catheterize themselves just in case they go into retention. But it's also important to realize that even if they go into retention, it's just temporary. The Botox is going to wear off eventually. So with extreme cases, there's the option of just leaving a catheter in the patient. Not a good idea. You have to be really, really, really desperate, and the patient has to be like at the end of their rope for you to do that, because catheters are a source of infection. There are 2 ways to do it. Some people just put it in the urethra, very uncomfortable, or you can do a suprapubic catheter where you just put the catheter, directly through the abdomen above the pubic bone, and you just, punch a hole in it, put the catheter in, and leave the catheter there, and it drains, and then the patient doesn't have to worry about going to the bathroom, and they can just empty there fully. But they need to have the catheter changed maybe every 6 weeks, and it increases the risk for infection, of course. And then in extremely severe cases, you can just divert the urine from the bladder, or do it cystoplasty by trying to increase the bladder capacity surgically. But it's like an overkill. So that's pretty much it about an overactive bladder. Any questions? Yeah.
So we have a patient in the ward, the one with the diagnosis of
yeah.
But part of the history that the patient came with was she was dribbling urine involuntary.
Yeah.
So the question is there an overlap between maybe stress incontinence and overactive bladder? If there is, where do you draw the line and come up with that?
Okay, that's a perfect question, a really good question. So the difference between stress incontinence and overactive bladder is that overactive bladder, you're dealing with like the nervous system. But with stress incontinence, it has to do with anatomy. So basically, stress incontinence just means that the woman has lost support of the pelvic floor. So the support of the pelvic floor is weak. And what happens is that with the way the pelvic floor muscles function is, so the bladder is directly behind your pubic bone, and it lies on the lower part of the uterus and the vagina. Between the uterus and the vagina, you have a plane of tissue that's called the endopelvic fascia. And so that acts kind of like a hammock. So when you cough or you laugh or you pick something up heavy, it helps support the bladder so she doesn't leak. And the urethra is held at a steady angle. So usually when women have children, that thing stretches, or as they get older, it gets weaker. And so when she coughs or she laughs or she sneezes, the support is weak, so she leaks some urine. So the difference with overactive bladder and stress incontinence is going to be based on the history that you take from the patient. With stress incontinence, they're going to leak small amounts of urine with activity. So that's the clue. Sometimes they may say, you know what, I don't really believe that I leak with activity. I don't feel it when it happens. Because maybe if their pelvic floor is weak enough that they're doing, pick something up and they don't really pay attention, they may leak. But it's usually a small amount of urine. With overactive bladder, it's urgency urinary incontinence. So the bladder muscle just contracts. They get the urge, they want to urinate, but they can't make it to the bathroom. Or they don't feel like they need to urinate, but as soon as they stand up, all of a sudden they get a really strong urge. Some people have like a mild urge, but even with that mild urge, they can't make it to the bathroom. The thing is that a lot of women, over 40%, it overlaps. So they can have both stress and urgency urinary incontinence. And then you say they have mixed incontinence. Okay, and the treatment for them, you can use the pelvic floor exercises, which we'll talk about later. But after that, the treatment is different. One has to do with support, one has to do with like medication and changing the way the patient deals with fluids and stuff like that. Does that answer your question? Okay. So, any other questions? Okay.
The neuromodulation that you use, you said you put the pacemaker at S1, S2. Does it have any other side effects? Does it stimulate any other nerves because you have other branches as well?
Yeah, so basically with the neuromodulation, you're trying to affect S1, S2, but there's nothing that's just going to be very specific. Okay, so when we do the procedure, the sacral nerves, it's S2, S3, and S4. Okay, and if we find that if we put it in like maybe S3, it's going to affect your bladder, but those nerves also have both sensory and motor. And so you can make the patient uncomfortable by stimulating the motor aspect. So they have like this throbbing sensation in their legs, or the leg jerks because you're affecting the motor nerves with that. So when we do it, it's kind of like a fine tuning. And it's not specific for just the overactive bladder. For some reason, we can use it for two things that seem like they're completely opposite. So you use this exact same treatment done the exact same way for a patient who has urinary retention that's not obstructive. So like a flaccid bladder. So urinary retention is not obstructive. You can use neuromodulation exactly the same way, and it works. The overactive bladder, it works. Another thing that it works really well for is fecal incontinence. So patients who have anal incontinence, even our patients who have had like the chronic 4th degrees, and you repair them, you don't have to repair the 4th degrees for the neuromodulation to work in them. Because before we used to go back and do the sphincteroplasties, but we all know that sphincteroplasties restore anatomy, but the function doesn't necessarily improve. And even if the function improves, most patients by 5 years out from their initial surgery will be incontinent or physis again. But with neuromodulation, they do pretty well indefinitely. And so it's the same treatment that we're using for several different things, but it works probably because it's kind of like very vague, and once again, it's plasticity. Yeah. Okay.
Okay. Let me just ask, I think the presentation is very educative. I want to ask if there is any role for urethral plugs for stress or overactive bladder. The other thing is we talk about overactive bladder more often in urogyne. What about in men? How common is it in men also?
It's very common in men. So the incidence of overactive bladder in men and women as we get older is not uncommon. The treatment is pretty much the same. You can use the Botox for, you do behavioral therapy, avoiding bladder irritants and all that. You do exactly the same thing in men. They can use medication for men. Men have the other problem of the prostate. And so as men get older, they get the urgency, frequency, but when it's a prostate that's involved, they have hesitancy. And so the treatment for that is slightly different. That's why you use the medications that try and, make the muscles around the prostate a little bit more relaxed so they can urinate. But overactive bladder is just as common in older men and women. It may start earlier in women, but the incidence is about the same. It's just that stress incontinence is much more common in women. With the plugs are obstructive. And so basically, their function is for stress incontinence. They're not really going to make too much of a difference for overactive bladder because anything that's a foreign body in the bladder is going to cause irritation, so it may make that actually worse. Am I making sense? So it's like the overactive bladder is digestive instability. If I put something in the bladder, it's going to irritate it more and may make it worse. But for stress incontinence, that's just pure anatomy. So it's support. So that's where the plugs come in. The other thing that we can use are something called a pessary. And a pessary is just like a plastic device which we can fit in the vagina. And it works for two things. It can help support the pelvic floor. So if a woman has prolapse, like the vaginal walls and the uterus are falling out, we put it in and it holds everything up. It also puts pressure under the neck of the bladder and supports the urethra. And so when she does something heavy, there's that support and she doesn't leak. So it's just like causing an obstruction there. And the good thing about the pessary is that you can take it out and put it in at will. And then the plug is actually just putting it in the urethra itself to block the urine from just leaking out. Yeah.
There's another question.
Okay.
Mine is concerning the management. You've spoken on the case stages. The first one, behavioral change.
With what? Sorry.
In the management of overactive bladder.
Yeah.
The first one you spoke about was reduction of energy intake.
Yes, so the first line treatment, the behavioral management, yes.
Management. The second one is medical, where you give antihistamine.
Yeah, second line, yeah.
The third one is more invasive, where you go.
Yeah.
Now, my question, it's actually a two-part question. The first one is, when you're managing, is it like a flow chart where you start the first line, second line, or are there overlaps where you can use both?
You can overlap, but my preference is that less is more. Okay, because everything we do has consequences. And like I said, with the second line treatments, it has potential side effects. There are going to be patients that you can just do behavioral management and they're going to do well. You just teach them things to avoid. They do the bladder training and stuff like that. And if they do well with that, there's no indication or no reason for you to add medication. So if a patient does that for a while and she's doing fine, then you don't need to do anything else. But if she does it for a while and she's like, I'm much better, but, I feel like I could be better, I'm still leaking and everything, then you can add something else. Okay, like with my older patients, I try as much as possible to avoid medication in them. If I can get them comfortable with just the first line treatment, that would be my preference because I don't want to have them deal with the side effects of the anticholinergics. With younger patients, I'm more likely to give them the second line in addition to the first line or, mix them more easily. But yes, it can overlap. You don't have to just say you're going to just do one or the other.
My second question is, this is a chronic condition.
Yeah.
So if you opt for the medical therapy, are you going to put the patient on antimuscarinics for the rest of their life?
That's a possibility, and it's like, you don't know. It's a chronic condition. It tends to be something that the patient may have to deal with forever. In some patients, it waxes and wanes. You're going to have patients who take antimuscarinics for a long time. They forget they're taking it. It's just part of their medication. It's not working anymore, but they're still taking it. You're going to have patients who take it for a short time and then they stop, and then their symptoms come back. So that's why I think that the first-line therapy is the most important, because that's something a patient can do forever without potential side effects, as opposed to the medication, which you're going to say you're going to need to take indefinitely. So it's not like you're going to treat the patient for 6 months and the patient's going to be fine, because usually if you take away the therapy that you're doing, then the patient is going to regress. But with the behavioral treatment, it's something the patient can sustain for the rest of their lives, and they know that if they do that, then it helps control their symptoms. But yeah, because it's a chronic condition. Okay, so I'm just going to briefly talk about pelvic floor exercises, because I think it's important and it's part of the first-line treatment. With pelvic floor exercises, all you're trying to teach the woman to do is a few things. Recognize and identify her pelvic floor muscles, okay, and then use those pelvic floor muscles to control her symptoms. Let me see if I can get out of this. Go 1 second. So the pelvic floor muscles are the muscles that, if the best way, most people, if you tell them squeeze your pelvic floor muscles, they're going to squeeze their buttocks or squeeze, but you have to just, so we call it the levator plate, okay? And that's the muscles that sit in the bowl of the pelvis and support our pelvic organs. So they're always in kind of a state of slight contraction, so they can hold things up. And if we have to be able to teach our patients to recognize those muscles. And the easiest way to recognize the muscles is you ask a woman to urinate and tell her to hold her urine. If she's able to stop her urine, that's her pelvic floor muscle that she's using. Okay, you don't want her to do that regularly. That's just so she can identify the muscles, because stopping your urine in midstream can cause you to have voiding dysfunction. Another way is when you examine the patient. If you put the finger in the vagina, you ask her to act like she's trying to pull the vagina, pull your fingers into her vagina. That's the pelvic floor muscle she has to use to do that. And so the pelvic floor muscle exercises can help control both the overactive bladder, and it works very well for that, the stress incontinence, and even fecal incontinence. And the way it works is that for the stress incontinence, you just make those muscles stronger, so that when she wants to cough, you teach her to squeeze those pelvic floor muscles and then cough, or you squeeze the pelvic floor muscles to pick something up. You squeeze the pelvic floor muscles when you're going to sneeze. And if you can get it strong enough, then it helps support the bladder and she doesn't leak that much. With the overactive bladder, squeezing the pelvic floor muscles, remember how we talked about the normal function of the bladder? If the pelvic floor muscles are squeezed, the bladder itself has to be relaxed. When you want to urinate, pelvic floor muscles relax and then the bladder contracts. Okay, so if the pelvic floor muscles are contracted, the bladder has to relax unless she's got some neurological problem. So with the overactive bladder, what you're teaching her is that when she gets the strong urge to urinate, the fear is that, oh my God, I'm going to leak, so I want to run to the bathroom. Well, if you're running to the bathroom, your pelvic floor muscles cannot contract. They're going to be relaxed and then you leak. So you teach her how to slowly suppress that urge by, when she gets that strong urge to urinate, instead of racing to the bathroom, she stops and she squeezes those pelvic floor muscles. Okay, it will take some time for it to become effective as she learns, but eventually she should be able to squeeze the muscles and force the bladder to relax. Once the bladder has relaxed, then she goes to the bathroom. Does that make sense? Okay, so that's with the exercises, but it's something that she has to practice and she has to learn how to do, and it's something that we probably should all be doing anyway, and it's best to learn it early so that when you actually need it, you can use it, or so that you don't ever really need it, So it's basically, it's not just squeezing, but it's knowing how to squeeze, knowing how to coordinate the squeeze to protect herself, and that's like, it's time intensive for the patient, but it's easy to teach, and you don't have to write a prescription for it. You just teach a patient how to do it, and you want them to do like maybe 10 repetitions of that, maybe 3 times a day, and if they keep doing that, they will eventually get comfortable, okay? And it's like when they're squeezing the pelvic floor muscles, you have to try and teach them so they don't squeeze the buttocks, because if you're squeezing your gluteus, you're not really squeezing your levators, okay? And it's like a difficult concept because it's not a muscle group that you can actually see. So the easiest way to teach them how to recognize or identify that muscle group is by having them try and stop their urine midstream. So you start urinating, you squeeze, see those muscles that you use to stop the urine, those are your pelvic floor muscles. But you don't want them to do that, stopping their urine midstream regularly. It's just so that they can identify those muscles that they will use for the exercises, basically. And I will send via email just like the basic patient instructions. I'll ask our physical therapist to give us stuff, and I'll send it to Dr. Mitei so that he can have that available for you guys. Okay.
You're done?
I'm done. Okay.
So thank you very much.
Thank you very much, guys.
A clap. I think we have learned a lot. Quite a number of times we see these patients, and we find they have been given antibiotics and antibiotics and antibiotics and antibiotics. You find they come a lot with vaginal discharge because of candida, with current antibiotic use. So first thing that you do, rule out any cause. Do a urinalysis. If there is no infection, then probably it's overactive bladder. If there's infection, you treat. If there's a stone in the bladder, you treat that. Okay? So thank you very much for coming. I think we will go back to our respective departments.
Thank you very much, guys.